Enjoy your meeting.
Really, most of the...
Just a reminder, today's meeting is being recorded.
Most of the disclosure is really not related to my talk, and probably the one disclosure would be that I have really devoted my really life on developing this device. Been doing this for about 13 years now. So I do have some I might be able to share with everyone. Today I'm going to, in general, go through the instrumentation of EBUS. Doing EBUS. I will give general tips and tips on needle manipulation during EBUS. Okay? This is perhaps going to be the most important part of my talk today. And this comes from lessons learned from fine needle biopsy. And this is a very long history of cytologists performing fine needle aspiration biopsies. There's a lot of things that we can learn from this, and certainly I've been able to use the previous knowledge from cytologists and apply that to EBUS. I'll talk a little bit about the importance of selecting the target when you do the EBUS. What is also important is how you handle the specimen, because if you do not handle the specimen properly, you're not going to be able to give the cytologist a proper specimen. And also talk about other technical aspects in general concerning EBUS cDNA. So in terms of the instrument, when you say endobronchial ultrasound, we have the radioprobe EBUS and the convex probe EBUS. And I'm sure everyone on this webinar is aware of the EBUS technology, but today my talk is going to focus on the convex probe endobronchial ultrasound used for EBUS cDNA. Currently, fellow systems are from Olympus, Pentax, and Fujifilm. Slide that you show is the current Olympus convex probe EBUS system. This is a second generation EBUS scope which has a 2.2 millimeter channel. The first generation had a 2 millimeter channel. The optics is located here on my arrow, and it's a 35-degree forward oblique view. And we use a balloon attached on the tip of the EBUS scope and the dedicated needle to do the EBUS cDNA. Different processors can be used. The first type, which is on the left, UC60, is not available anymore. They don't make this. The EUME1 was the second generation, and the newest one on the market is called the EUME2. The Pentax EBUS scope is slightly different than the Olympus system. The main difference is the CCD on the tip of the EBUS scope. Pentax put the CCD on the tip, which allows for a better endoscopic image. The problem that I see by doing that is the non-bending is a little bit longer than the Olympus system, which kind of makes the actual EBUS cDNA a bit challenging, although the endoscopic image is better. I think the Fujifilm system that recently came out is probably combining both of the technology, Olympus and Pentax, and putting it into a relatively smaller tip. So with the smaller CCD chip on the tip, it allows for a shorter non-bending tip, and also the unique part of this Fujifilm scope is that it's a 10-degree forward oblique view compared to a 35 forward oblique view for the Olympus system. So you have a better endoscopic image, and you're seeing the image similar to a regular flexible bronchoscope. So a combination of the technology. Needles are important because even if you can see the lymph node without a needle, you will not be able to get any tissue. Currently, there are the 21 gauge and 22 gauge needles available from Olympus. And there are other companies that have come up with different devices. The Mediglobe Sonotip EBUS Pro Flex is a made out of nitinol and eliminates needle deformation. And I think everyone has experience when you are sampling lymph nodes where you have to angle the tip of the bronchoscope significantly. Once you do the biopsy, the needle tends to bend. By using the nitinol needle, Mediglobe has been able to eliminate the needle deformation. I think one of a different needle that came out from Cook Medical is called the Pro-Core EBUS needle. Now, this name may confuse people because it kind of assumes that you're getting a core, the Pro-Core needle, but the biggest difference is that it has a side hole on the tip of the needle, which allows you to cut into the tissue, but you're only using a 22 gauge and a 25 gauge needle for this. So it's really not a true core that you're getting. I do have experience with both the Olympus, the Mediglobe, as well as the Pro-Core EBUS needle. There is a tendency that you would get relatively more bloody samples when you're using this side hole needle. And there has not been any studies that have actually compared the different needles. I have done some comparison in animal models, which I have not published, but in general, my experience has been that you tend to get a little bit of a bloody sample when you use a 22 gauge Pro-Core needle. So this is to summarize what EBUS allows us to do. It was really first developed to stage patients with lung cancer for lymph node staging. The extent of lymph nodes that are accessible goes beyond mediastinoscopy. I think that is going to be a strength in future management of patients with lung cancer by being able to sample the N1 nodes. Mainly, EBUS procedure is done under local anesthetic with constant sedation, so it is a minimally invasive modality. Sensitivities reported have been very high, and now it has been considered the first choice of sampling lymph nodes in accessible areas. These are the other applications of EBUS and staging of lung cancer. You can use the EBUS scope for sampling intrapulmonary tumors as long as it's in the reach of the EBUS scope. And there has been a growing evidence of use of EBUS for sarcoidosis as well as lymphoma. And I think in terms of the sensitivity varies from 57 to 91%, and this is really dependent on the person doing the performance and also the cytologist processing the sample. Now, EBUS is considered the test of first choice as shown in the ACCP clinical practical guidelines for lung cancer. So I think in less than 10 years since it's been in the market, I think there's been a significant amount of interest and studies on the use of EBUS DNA. So I've gone through the literature and kind of will show some of the things that I've discovered and also share my experience. And today's really role was, this webinar was to help people improve their EBUS yield. Anesthetic for EBUS, there's different ways that are being done. I think it depends on the clinical setting, whether you do this in a operating room if you're a surgeon, or if you are doing this under sedation, if you do have the proper personnel to do that. But in general, it can be done with conscious sedation with excellent patient satisfaction. If you are doing this under general, probably using a laryngeal mask airway is better than the endotracheal tube, because by putting the endotracheal tube into the trachea, you are limited to sampling the lower peritracheal lymph nodes, and the higher peritracheal lymph nodes are somewhat difficult to sample. But if you do decide to use a endotracheal tube, you need a size larger than 8. For LMA, you need a size 4. This is a most recent randomized controlled trial that was published by Roberto Casal in Texas, and they looked at general anesthetic versus moderate sedation during EBUS TBNA. And the goal of this study was to determine whether the types of sedation influences the diagnostic yield of EBUS TBNA, its complication rates, and also the patient tolerance. And in this study, there was no difference in the number of lymph nodes or lesions sampled per patient, constantly about 3 stations with GA versus moderate sedation. The diagnostic yield was similar, around 70% for all comers. Sensitivity was similar. Completion rate was a little bit better in the general anesthetic group, 100% versus 93.3%. There were no major complications in both groups. But looking at the minor complications, there was a significantly more minor complication with the moderate sedation group. So when we do EBUS, there are several things that you need to think about, and this slide is probably the most important slide of my talk today. It's unpublished data, just based on my experience, and this is the general tips. So always start with a white light bronchoscopy, and this is for several reasons. If you are using the EBUS scope, you don't really get a chance to see the mucosa very clearly, and you are limited to how deep you can go in with the bronchoscope. So always start with the white light bronchoscopy, but it's not just for examination, but it's also application of local anesthetic throughout the airway. And I try to give more lidocaine, especially in the focus area where I will be sampling the lymph node. Also, very important to keep the airway dry. With the white light bronchoscopy, I try to suction out all of the secretions before going in with the EBUS scope. When you go in with the EBUS scope, be aware of the forward oblique view on the convex probe EBUS. There may be discussions about this later, but I always use a balloon in all my cases except for patients with latex allergy. You get a better view of the lymph nodes or your lesion, and even when you're doing the EBUS TBNA, I think that balloon does help. The other key of performing a successful EBUS is to always keep the EBUS image, endoscopic image, clean. And this is probably something that needs a lot of practice. When seeing my trainees, although they might be able to do an EBUS TBNA, they sometimes have difficulties cleaning the camera head. So what I do is I try to rub the tip of the CCD camera on the right main bronchus or the membranous portion to really clear the fog. Also, avoid any blood from accumulating or any secretion from sitting on the camera head for a long time, because once you do that, you won't be able to clean the camera. The reason why it's important to keep the camera head clean is because when you do the actual TBNA, you need to look for landmarks on endoscopic image. Means the entry point. You're always looking endoscopically where you're going to actually wedge your needle, and this has to be between the cartilage. If you cannot see this, you're kind of guessing. If your needle hits the cartilage, your needle will push off your airway. You'll lose your ultrasound view, and you struggle. So look for landmarks on the endoscopic image. When you are visualizing the lymph node, make sure you keep your EBUS scope straight so that your hand holding onto the bronchoscope can, just with your left hand, I use the left hand, you can visualize the lymph node at a certain angle. And you really have to memorize that angle of view when you're entering into the airway. Another thing that I have noticed when beginners start doing the EBUS scope, they tend to hold the top of the needle for some reason. And when you do that, you won't be able to push the needle into the lesion. I try to hold the bottom part of the needle device and really fix your hand so that you can manipulate the needle and have control with your fingers. Next important thing, so you look for landmarks, you memorize the angle of the probe with your left hand, you then wedge the needle in the intercartilaginous space. When you push the needle in, you have to always maintain the appropriate angle, which is with your left hand at the time of penetration, because if you're struggling, if you push the needle in between the cartilage, and if your angle is off, the needle will only go in one direction. So even if the needle's in, you may not be able to get the target. So this is really the key steps when you're doing the EBUS TBNA. I'm not sure if this movie is going to project very well, but this is to show you one of the cases that I recorded about 7 years.
Kazu, sorry to interrupt. I think you're not sharing your screen anymore. Can you?
Really?
Yeah. Can you just try again?
Okay. You're right. When did I stop sharing?
Just 30 seconds ago.
Okay, 30 seconds. Sorry about that. Am I back? Can you see me now?
Yes.
Okay, sorry about that, everyone. So this is a short video that I recorded about 6-7 years ago, and I still use the same technique. When you load the needle, always see your endoscopic image, and I want everyone to appreciate how clean the endoscopic image is, because you're really looking, right now I'm looking at the endoscopic image, and I usually always have 2 big monitors to look at both ultrasound and the endoscopic image. You load the needle at the neutral position, then that's when you flex the tip. But what I'm looking at right now is really the endoscopic image. I try to wedge the needle right between the cartilage. And if you look at my left hand will never move. The angle will never move. And that's how you maintain the plane of entry. You can do that, and if you can avoid going onto the cartilage, then you can sample a very small lymph node, like this case, patient 4L, without any difficulties. So this is another, I think, very important thing that I would like everyone to really think about. And this slide was given to me by Dr. Getty, who is one of our cytopathologists. They have been doing fine needle biopsies for a long, long time. So if you look at the literature within cytology and fine needle biopsies, there's lots of data that actually you can use and implement when you're doing the EBUS scope. Really the key of getting good samples is that when you put the needle into a lesion, it's really the forward stroke that is important. And it's the needle acts as a mini scalpel, which dislodges the cell and tissue fragments from the surrounding stroma. So if you cannot do this forward stroke with the EBUS TBNA, you're also not going to get anything. And there's been lots of discussion about, are you going to aspirate or not? Are you going to put suction or not? And from the literature, it appears that applying suction or not does not really affect the quality of the samples on a fine needle biopsy. And this is a little article about fine needle sampling without aspiration. And I think the same concept we can apply to EBUS TBNA. Now, why does fine needle biopsy fail? And this is, slide is just about their experience in fine needle biopsies. And usual reason for failure is sampling error. And this is exactly the same for EBUS TBNA. If you did not go into the right area within the lymph node, you're not going to get a good sample. And also, in very vascular lesions or lymph nodes, you're going to be filling your needle with blood. So if you have blood in the needle, even if you aspirate or if you move the needle many times, all you are going to get is blood. So in those cases, what they do is they use a smaller needle. And I think eventually this is what is going to happen for EBUS TBNA when there are smaller needles available. I have some experience using a smaller EBUS needle, and it gives you really excellent samples. So this is a picture of a sentinel axillary lymph node, and you can see the part of the tumor versus normal part of the lymph node. And if you really cannot sample the right place, a lymph node is a lymph node. There could be metastatic disease within one area of the lymph node. So really the target is going to be important. So this is the central concepts of fine needle biopsy. You really need to spend time positioning. This is, for EBUS, refers to positioning of the needle. You cannot think that bigger needle will give you a better sample, because it doesn't. The needle has to move in the lesion, meaning that the needle has to really move with the target fixed. Now, if the target cannot be fixed, for instance, if there is a surface lymph node, if you can fix it, that's fine. But if you're trying to sample something that you cannot fix, a quick jab movement is really necessary. And this is exactly the same for EBUS. If you are sampling a relatively large lymph node, usually those lymph nodes are fixed onto the mediastinum. You can sample this very easily, but for smaller, normal-looking lymph nodes that are kind of floating within the mediastinum fat, then you really need to jab and move your needle very quickly to get any samples at all. Another key is don't leave the needle inside of the lesion too long, because if you do, you're going to get a lot of blood. And if you do get the sample out, you should process the sample before it starts to clot, because then you won't be able to process your precious sample. So this was about fine needle aspiration biopsy, and this really applies to EBUS TBNA needle manipulation. needle movement is very important, and it's really the fourth stroke. This really makes a big difference on amount of tissue that you can get from doing this. The needle has to really move within the lymph node. For small lymph nodes, quick jab motion is necessary. You need to target the lesion appropriately, avoid blood, don't leave the needle in the lesion too long, and try to process samples quickly to avoid clotting. Momin, how are we with the time? Are we still okay?
Yes, we're doing okay. We have 10, 15 more minutes, and then we'll start the questions, so you're good.
Good. So those were the really key points, I think, that I wanted to share with everyone. But selecting the target, and I've shown this slide, and I'm just going to go through it very quickly. Understanding this sort of anatomy, what you are seeing around the trachea, around the bronchus, where is the lymph node, where is vascular structure, is really key, because you really have to memorize the landmarks when you are doing sampling of the lymph nodes. This is in the right main bronchus. You have to understand that station 10R is distal to the azygos vein. 4R is proximal to the azygos vein. If you mistake that, you're going to be upstaging the patient. So this kind of bronchoscopic anatomy is very important. And for people who are interested in this kind of anatomy, I can send you these slides. On the left side, you should be looking for the left main bronchus, identifying station 4L, station 7, 10L. And when you go down into the upper and lower lobe, what you should be seeing is, or looking for, the main PA branching into the suprasegmental branch, different branches of the PA, and the different lymph nodes around the different vessels. So you really need to understand this anatomy in order to really identify each of the lymph node stations. And up in the trachea, you have to identify the aortic arch and the subclavian artery, the brachiocephalic vein. All of these structures, vascular structures, become key in identifying the different lymph nodes. This slide is also very important because once you start doing EBUS, you're going to be seeing many, many lymph nodes. And the more detailed examination you do, the more lymph nodes you'll see. And you'll recognize that there are lymph nodes that will start to look normal to you. And really to define that, we did this study a while ago, and we looked at thousands of lymph nodes, and we came up with this standard EBUS image classification. If the lymph nodes are small and is oval shape, indistinct margin with a central hilar structure present, these lymph nodes are likely going to be non-metastatic. Now, if it looks suspicious, you always have to sample it, but I think the problem is if you see 15 lymph nodes, you cannot sample all of the lymph nodes. So you have to take into consideration the results of the PET scan, CT scan, the investigational probability of metastatic disease, and in addition, include this EBUS image that you're actually seeing during the procedure and think about what you need to sample. Also, you can look at vascular patterns within a lymph node, and you can maybe look at this article that we published. It's not as easy as the EBUS standard classification, but when you use the Doppler mode to identify these vascularity within the lymph node, you can actually grade the lymph nodes from grade 0 to 3, and that will help you identify whether a lymph node is metastatic or not. Grade 0 and 1, negative finding, grade 2, 3, and the BA inflow sign as positive finding for metastatic disease. There are different ultrasound imaging modes that have been used in other fields other than the EBUS. We all know the B mode, M mode, and color mode, color Doppler, but there's also the harmonic imaging, elastographic imaging, contrast agents during ultrasound. And I think these newer imaging modes will also become available for EBUS as well. The EUME2 has a new modality, the pulse wave Doppler, the H-flow, and also the elastography. Whether this is going to be helpful or not, we're not sure. But in general, elastography looks at how hard the tissue is. And assuming that a harder tissue is going to be metastatic, you might be able to differentiate between a normal lymph node versus metastatic lymph node. This is a case with a benign lymph node on the left, more of a green color, versus malignant lymph node showing more of a bluish color. So rapid on-site cytology is something that we always discuss about meetings, and the specimen handling is very, I'm not sure if you can see the video well, but when I was in Japan, this is the way that I was processing my specimens. I would push out the core or blood clot into a filter paper and put this in formalin, send that to pathology, and the rest I would make a smear and send this for cytology. So from one needle, I would have a pathological specimen and also a cytological specimen, which allows us to look at samples like this, and you would have the advantage having histology as well as cytology. But coming now to Toronto, where the cytologists have a lot of experience, we now do a bit of a different way of processing samples. If we have rapid on-site cytology, I give them a small drop on a glass slide, they make a smear, they will dry part of it, fix some of it on alcohol, and the rest will go into a 50 cc conical, which you can see in this video. And from this, they will make a cell block, so we do not waste any of the aspirates. So everything goes to the cytologist. And based on this, they can make a cell block, and using the cell block, you can do different kinds of immunohistochemistry and do all the mutational analysis. And one of the goals of rapid on-site cytology is really to optimize handling of samples, determine if sampling of target has been achieved, and also what is really important is the triage of material for ancillary tests. Now, if you do not have rapid on-site cytology, you have to figure out whether you need to do culture in the patient, whether you need to send it for lymphoma, for flow cytometry. That is something that you will not have with a rapid on-site cytology. But you should always be cautious about the results of rapid on-site cytology, because it is rapid on-site cytology. It's not really the final report. We looked at our data from Chiba University of 438 cases, and we wanted to see how the rapid on-site cytology results correlated with the final results of cytology. And in our experience, there was no false positive. So if they call it positive, it was always positive. That's in our experience. But there were 25 cases that was false negative on rapid on-site cytology, where on the final cytology, it was actually positive. There has been a study done by a Japanese group looking at a randomized controlled trial looking at the role of rows during EBUS. They looked at rows versus no rows during staging for lung cancer, and they showed that having rapid on-site cytology is associated with a significantly lower need for additional bronchoscopic procedures, which kind of makes sense because you will have the answer right there. I'm going to skip this slide for the sake of time. This is probably the most recent publication. I'm not sure if everyone has seen this, but there has been a randomized controlled trial of the role of rows for lung cancer genotyping. I think this is very important. They looked at using rows versus no rows, and the primary endpoint was the rate of successful molecular profiling for EGFR, KRAS for all, and plus or minus ALK testing. And complete genotyping was achieved in 85.7% of the patients. The rows arm less likely to have samples that could only be used for pathologic diagnosis, and by having rows, more likely to have the bronchoscopy terminated after a single biopsy site. So similar to what I showed you in the first slide, I think it does help in the management of these samples. I have several more slides. I should be done in a few minutes. Other technical aspects which I'm asked a lot, how many aspirations should you do? This is different than how many lymph node stations should you sample. The first study by Lee from the Korean group, they looked at how many passes should you do per lymph node. And in this study, they do not use rapid on-site cytology. They did not have they did not look for molecular analysis. In that setting, if you do 3 passes, you reach the plateau. So you should sample at least 3 times per lymph node to achieve the maximum yield. Now, how many lymph nodes should you sample to be called a proper staging? And in this lower study, they concluded that you should sample more than 2 mediastinal lymph node stations. And from my experience as a surgeon, if you are going to call it proper staging, you must sample at least station 4L, 4R, and 7. Even if the lymph nodes look normal, unless you sample it, you're not going to be able to call it a proper staging. Larney Yarmus looked at how many passes needed for molecular analysis, and in their study, a median of 4 passes were needed for adequate molecular profiling in 95.3% of their study cohort. So I think in general, you need more tissue for molecular analysis, and you really have to decide based on what you're seeing if you do not have rapid on-site cytology. And the other question that I'm asked is, do you use a 21 or a 22 gauge needle? And this was the first study that we looked at 21 and 22 gauge needle in various cases. And in our experience, there was no difference in the diagnostic yield. There was more blood contamination in 21 gauge samples. What I do right now is I usually use a 22 gauge needle, and I only use 21 gauge if lymph node is very hard, for instance, in sarcoidosis. There is a big study, again from Lonnie Armis, looking at the acquired database, comparing 21 versus 20 gauge. And in this study as well, there was no difference in sample adequacy. But with rapid on-site cytology available, there was significantly fewer needle passes per procedure when using a 21 gauge needle. I don't know what that means, but in general, I don't think there is a difference in 21 versus 22. Suction or no suction, what you should avoid is giving the cytologist sample like this full of blood. And in order to do that, you can think about different things. This is another randomized controlled trial comparing suction versus no suction for EBUS. And in this study, there was no difference. And when you remember the slide that I showed you given to me by the cytologist, it's really not the aspiration that is important, but it's more of the movement of the needle. My practice, which is not published, I use the Doppler mode if I see a very vascular lymph node. I try to avoid the vascular part of the lymph node. So in this case, I would try to go here. I would start with suction. If the aspirate is very bloody, I would repeat the procedure without suction. And when I do it without suction, I don't take out the stylet all the way. I pull it out halfway to achieve a capillary sampling. For subcarinal lymph nodes with very higher vascularity, I start without suction. So this is my current practice, which I wanted to share. So to summarize, I think these are the take-home message for checking in our webinar today. To understand the equipment, know your anatomy, find the appropriate target, meaning not just the lymph node. You need to find the right lymph node, but you need to find within the lymph node where you're going to place the needle. You should avoid the parts that are vascular. You should try to sample parts that look suspicious, because even in one lymph node, there are parts that look suspicious versus non-suspicious. The needle, again, has to move in the lesion, and do not think that using a bigger needle or even syringe will give you a better sample. And always try to avoid bloody samples and try to handle specimens properly. And when I say properly, it depends on your cytologist. So you should really sit down and discuss with your cytopathologist and come up with the best protocol that will suit you. So thank you very much, everyone, for your time. That is the end of my webinar.
Yeah, thank you so much. Please stay on. We're going to open it for discussion and questions. Kazu, that was a tremendously informative presentation. Thank you for sharing your experience and wealth of knowledge. Please type your question in the chat box. I see the first question, Dr. Emir Abramovich. I'm going to unmute you, and can you ask the question, Dr. Abramovich?
Hi, can you hear me?
Yes, we can.
Okay, so looking at the experience of our fellow gastroenterologists, they are using the spanning method, which is actually bending the scope with the needles inside the lymph nodes, usually big nodes, in order to sample various areas of the same node during one stroke. I didn't hear about any experience using EBUS doing that. Do you have any experience with it or any opinion?
Can you repeat the first part of the question?
I was looking at the experience of our gastroenterology fellows doing EUS. They are using the fanning method, which in that way that you can move the scope with the needle inserted in the lymph node or in the lesion, so you can actually sample various areas without taking the needle out. Do you have any experience with that method?
Yes. So if I may answer, what I tried to show is that because of the airway being very rigid, once you pass the needle, then you can't really move the needle like you can move during EUS FNA. The esophagus is very soft, so it's very easy to move and fan the needle. That is really not possible in a way that you would be able to do it in EUS FNA. So I think you need to really select the target. You need to direct your needle towards your target, I think. It's not, I've tried it, but it does not really work. Having said that, I do EUS as well, and EUS is much easier to do that, just because the esophagus is very soft.
Thank you.
Great. Thanks, Amir. So fanning is not recommended in EBUS, or I mean, it may or may not do anything. So I have a couple questions, Kazu. First, when you process your specimen, trying to expel it into the slide, does it matter if you use air to push the specimen out, or do you use a stylet to push it out?
I think that's a very important part of handling specimen. And as you saw in my video, what I do is I use the internal stylet when I have a cytologist, when I need to make a smear. Because if you use air to blow out the specimen, you'll end up giving them too much on the slide. So when you have the cytologist there, when they're going to make a smear, or even if you don't have a cytologist, if you're going to make a smear, use the stylet, put a small drop on the glass slide. So for each glass slide, you make a very thin prep. Now, if we don't have the cytologist, what I do, I don't use the stylet. I just use the 50 cc conical or 20 cc conical and use the air to blow it into an alcohol fixative. We use the cytolite solution. For that case, I do not use the stylet.
So you start with the stylet to put a drop on the slide, and then you use the air to push the rest of it and potentially into the cell block, correct?
Correct, if I have cytologists there.
Okay.
If I don't,
great.
put everything in the alcohol fixative without the stylet.
Got it. One other question that comes up, people get frustrated, you have the needle in the lymph node, you see it under ultrasound, you come out and there's really minimal sample or no sample. What is your explanation? What should the operator do at that point?
So there's several things, and I've kind of noticed from watching my fellows how they get better in a year. It's really two things. One, when you start doing this EBUS procedure, a lot of the people will fail to clear the tip of the needle, and most of the time they won't be able to go through the airway in one shot. They'll end up, going into the cartilage, and each time you try to push your needle through the airway, if you can't go into the intercartilaginous space, you're going to have a lot of tissue on the tip of the needle. And once you're in the lymph node, you have to be able to clear that completely, because if you don't, you're just going to be sucking on this cartilage or airway. So that's why you won't get it. But I think as you start doing this, you realize that, and once you get better going through the airway, and once you get better clearing the tip, then it's the problem of movement of the needle. Even if you move the needle within the lymph node, especially for small lymph nodes, you really need to jab and move the needle very quickly. Otherwise, you're really not going to get anything. And for larger lymph nodes, as I shared in my slide, it's really the forward accelerated movement. You have to cut into the lymph node. That I think is going to be the key.
Great, thank you. We have a question from Christina Bellinger. Christina, you're unmuted. Please tell Kazu your question.
Oh, thanks very much. So I recently had our pathologist switch from cytolite collection. We were also doing similar needle rinses with air into the syringe, and they switched us to a saline solution, claiming that it was just as good, and I was wondering if anyone was aware if saline versus cytolite affects yield.
So I can answer that. It will affect the yield depending on how long it takes you to bring the samples to the lab, because if you put it in saline and if you do not process the samples quickly, the saline itself can blow up the cells. Saline is something that you should not keep your cells in for a long time. So if you're going to process this quickly, saline is probably better because you can do flow cytometry, you can do culture, you can do various things. That's what is good about saline. But if you cannot take your samples to the lab immediately, you need to put it in alcohol fixative because you need to be able to fix the cells. So I think it'll be more stable. And with the cytolite solution, there is a lysing component. So you're able to lyse the your blood within the sample. So that helps as well. The issue with the cytolite solution is that once you put it in there, you won't be able to send it for culture. If it's suspicious for lymphoma, you won't be able to do flow cytometry. So in our practice in Toronto General Hospital, when the cytologists are available, when they come for rapid on-site cytology, they usually take the sample. So we wash everything in saline because they will take it back to the lab immediately and process it immediately. And they have more flexibility of doing whatever test they want to do. But when we don't have the cytologist in the room, we cannot do that. So we process everything in cytolite solution. And we only have cytologists available for 2 cases per day. They only come for 10 cases per week for EBUS procedures. I think they figured out, when I came to Toronto first, they were coming for all my cases, but they quickly figured out that I'll be doing many, many cases, so they're kind of smart. I hope that helps.
Yes, thank you.
Thank you. One more question. Sometimes you just can't get the needle to go through that lymph node. It's calcified, or there's, and it's just you're trying your hardest, you're jabbing it quickly. Do you have any tricks? Is it just a calcified? Especially in elderly folks, sometimes we have this problem. Do you have any tips or anything for that?
Well, you need to come to the Yasafuku dojo. I'm just joking. But sometimes for the large lymph nodes, what I do is I take the stopper off, even if it's a relatively small node, and being able to advance the needle up to 4 centimeters, you sometimes get a better stroke. Sometimes you might end up going into the PA, but sometimes that'll give you that extra push to be able to penetrate into the capsule. It's usually the capsule of the lymph node, and also for really hard lymph nodes. I think for patients with very calcified lymph nodes or burnt out sarcoid cases, that's when I tend to use the larger 21 gauge needle, because sometimes it does help getting the fibrotic tissue. I hope that helps. So it's really the accelerated motion, I think, that's the key.
Wonderful. Well, I think we're coming to an end here. This was wonderful, Kazu. We'll get feedback from, there's one more question, I think. Let me see. I think it's just a suggestion or answer. This was wonderful. I think people enjoyed it. We'll hope to hear feedback from the participants today. By the way, this is recorded, so you'll be able to watch or hear this on the AABIB website. We'll send you a link. Also, we're going to have to do we'll do many webinars, hopefully once a month or every 2 months. Hopefully this will add value to you guys, our members in the AABIP. Again, Kazu, thank you so much. Thanks, everybody, for coming to participating with us here for an hour. Thank you very much, everybody.
Thank you for the organization, Moment.
Thank you. Take care.
Bye-bye.
Bye. Bye.